scientific basis for this. Because female-to-male transmission of HIV is extremely difficult, AIDS has never exploded into the heterosexual populations of the US and Europe, even though condom-less sex remains the norm. From 1985 to 1991, Dr. Nancy Padian and her associates studied 72 HIV-negative male partners of HIV-infected women. As reported in the Journal of the American Medical Association, 1991, they found only one probable instance of female-to-male transmission. As for sexual transmission in general, a definitive study in the British Medical Journal, 1989, by the European Study Group on AIDS concluded that the only sexual practice leading to an increased risk of HIV infection for men or women was receptive anal intercourse. Even the definition of AIDS differs from one continent to another. In Europe and America, AIDS-defining diseases include 29 unrelated maladies ranging from pneumocystis carinii pneumonia and pulmonary tuberculosis to cervical cancer. In addition, an HIV-positive test and a T-cell count below 200 are necessary for a confirmed diagnosis. But in Africa, the term AIDS is used to describe symptoms associated with a number of previously known diseases. In the mid-1980s, those common diseases were suddenly reclassified as special opportunistic AIDS-related infections, and Africans were warned to change their sexual practices through abstinence, monogamy and condoms or they would die. Hilary Standing, a British medical anthropologist and AIDS researcher, concedes that African risk populations are assumed rather than revealed. So why are AIDS cases in Africa nearly evenly divided between men and women? The answer lies in the World Health Organization's definition of AIDS in Africa, which differs decisively from AIDS in the West. The WHO's clinical case definition for AIDS in Africa, adopted in 1985, is not based on an HIV test or T-cell counts, but on the combined symptoms of chronic diarrhea, prolonged fever, 10% body weight loss in 2 months and a persistent cough, none of which are new or uncommon on the African continent. HIV tests are notoriously unreliable in Africa. A 1994 study in the Journal of Infectious Diseases concluded that HIV tests were useless in Central Africa, where the microbes responsible for tuberculosis, malaria and leprosy were so prevalent that they registered over 70% false positive results. Furthermore, everything we know about viruses tells us that they are equal opportunity microbes. They will attack men and women weakened by malnutrition, the most effective cause of immune suppression. Venereal diseases left untreated can also impair one's immunity, rendering any victim susceptible to other infections. Africans are often assumed to die from AIDS-like symptoms after their immune systems have been weakened by malaria, tuberculosis, cholera or parasitic diseases. By calling these deaths AIDS and claiming there is a new epidemic in Africa, are health officials from the West, perhaps unwittingly, helping to provide opportunities for development agencies, biomedical researchers and pharmaceutical companies who clamor for more money in markets. Certainly, promulgating the idea that AIDS is an epidemic caused by sexual promiscuity will deepen Africa's dependency on Western aid for diagnostic tests, high-tech sterilization equipment and medical personnel. Another consequence of having millions of Africans threatened by AIDS may be to make it politically acceptable to use the continent as a laboratory for vaccine trials and the distribution of toxic anti-HIV drugs like AZD. Vaccine experiments in the United States have been curtailed due to government regulations and fear of lawsuits from research-related injuries. However, according to a 1994 Rockefeller Foundation report, accelerating preventive HIV vaccines for the world, risky HIV vaccine trials would be tolerated, even welcomed in African countries. Because of the extraordinary time lag between HIV infection and onset of AIDS, now set at 6 to 12 years, AIDS activists warn that their awareness campaign will require many years of active government intervention and funding to overcome resistance to behavioral changes. These new missionaries with their messages of safe sex seem especially preoccupied with changing men's behavior. They want to turn African women into gatekeepers who negotiate sexual relations and risk reduction strategies. At the Yokohama AIDS Conference and the recent UN Conference on Population and Development in Cairo, feminists insisted that AIDS would be halted only when women were empowered to reduce inequalities, by creating networks that enhanced gender sensitivity and prevented sexual victimization. It is the political economy of underdevelopment, not sexual intercourse, that is killing Africans. Poor harvests, rural poverty, migratory labor systems, urban crowding, ecological degradation and the sadistic violence of civil wars imperil and destroy far more African lives. When essential services for water, power and transport break down, public sanitation deteriorates and the risks of cholera and dysentery increase. African poverty, not some extraordinary sexual behavior, is the best predictor of AIDS-defining diseases. AIDS skeptics should scrutinize ethnocentric stereotypes about African sexuality, and thoroughly reappraise the entire HIV equals AIDS orthodoxy. The purported link between HIV and AIDS was only hypothesized 10 years ago, but it has subsequently acquired a life of its own, especially among fundraisers and sex educators who, like the theory, remain immune to criticism. Of course, people everywhere should be encouraged to behave more thoughtfully in their sexual lives. They should be provided with reliable counseling about condom use, contraception, family planning and venereal diseases. But whether in Cameroon or California, sex education must no longer be distorted by terrifying, dubious misinformation that equates sex with death.